on di- diabetic nephropathy. So as you know, the responsible academic college, we, Sri Lanka College of Specialist Family Physicians, are always so in a mind to, promote, not only promote, share our expert knowledge with, the primary care physicians, because in this country, so-called GPs who are practicing without any qualification after MBBS, and as well as there are so many the senior practitioners as well, but they don't have any training like 4 years training in other countries like UK, Australia, and developed country with the very good systematic, primary care system. So our the main focus is to provide this knowledge, share this knowledge, because other countries, the primary care physician is a very well trained one with 4 years in the postgraduate training, and they manage most of the cases. That's how they have achieved, the safe, evidence-based primary care and the cost effectiveness to the country by not by overloading, the secondary care units as well as the tertiary care units. Unfortunately, since we don't have that, the primary care units are there in each and every hospital, that is the OPDs, according to the Ministry of Health circular. Those places are the majority, most of the medical officers are working compared to the secondary and tertiary care. They are where they are under supervision of consultant. But here, without any supervision and without any training, they are working. Fortunately, some of them are having DFM training. And now MRCGP exam also going on. Some of them, they do. So because of that, some patient safety we can. So, but still, as a college, our main responsibility is to share this knowledge to you all. And I have sent this to the other, the doctors who are in periphery, who join with us during the capacity building program of health ministry. So the knowledge is very important, and then you have to have your skill and art to gather the correct, the information, and to find out what this symptom of what the disease, right? There are so many diseases that same symptom can come, and as well as to confirm by identification, and then go to the correct counseling and management. So now today we are discussing this according to the real case scenarios that we are managing at our clinical places. Since I am attached to Base Hospital Panadura, my trainees are being, conducting this, the presentation on their own patients. So here today, Dr. Tharanga, is the registrar in family medicine, and he is going to do the presentation on particularly the diabetic nephropathy, and he is going to update you about, the evidence-based management, as well as how to, detect the problems of CKD patients, how to identify and how to treat. So this is a very good case that we manage the patient, and it's over to you, Tharanga. Dr. Tharanga, you can start it now. Thank you.
Okay, madam. Thank you very much. Good evening, everybody. Good evening, madam Malkantigal, and good evening, Madam Pasanatas, and good evening, all my dear colleagues. So, as Madam said, today my talk based on a patient I encountered during my appointment at BH Panadura. So, as it is close to 10, I will just directly go to the case. Can you all see my screen?
Yes, we can.
Okay. He is a 72-year-old male patient who was diagnosed to having diabetes mellitus, hypertension, and dyslipidemia. He was referred from District Hospital Bandaragama due to poor glycemic control and rise in serum creatinine. And he was having diabetes and hypertension and dyslipidemia for 10-year duration. was taking regular treatment from Bandaragam District Hospital. Currently, his symptoms, he complained of proteurine and he had bilateral leg swelling. He has no hyposmol symptoms suggestive of hyperglycemia, or he had no any symptom of shortness of breathing, no facial or abdominal swelling he complained. He had no loss of appetite or loss of weight. He had no bladder outflow tract obstruction symptoms. Uh, he had no any other symptoms of microvascular complication of diabetes except this uh, rise in serum creatinine. So his past surgical history, he had underwent bilateral cataract surgeries a few years ago. Now he has no any visual complaints. So he had no any disturbance to his psychological status. He worried about insulin therapy and he requested us to manage with tablets. He's a manioc vendor with unsatisfactory income and he is a sober. He is happy living with his family, but he has no focused diet. When he presented to our clinic, he was on glycoside 80 milligram BD, metformin 500 milligram BD, sitagliptin 100 milligram MANE, and empagliflozin 10 milligram daily. With atorvastatin 10 milligram nocte, losartan 5 milligram BD, and HCT 25 milligram MANE. So he had allergy to pork. And family history, her mother has had a stroke at the age of 70. On examination, he was sitting comfortably, not dyspneic at rest. He looks obese. His BMI was 32 kilogram per square meter. He had bilateral pitting ankle edema, and there were fungal infection in web spaces bilaterally. He was not pale, no facial swelling, no legs, no facial swelling. He had no any features of chronic liver disease. He had no goiter, no finger clubbing, no callosity, so diabetic foot deformities. Cardiovascular examination was blood pressure was 144 by 94, pulse rate 80 regular, dual rhythm no murmurs, JVP was not elevated, no bibasal crepitations. Respiratory system examination was normal. Abdominal examination, no hepatosplenomegaly, no palatable kidneys. CNS examination was normal, no evidence of peripheral sensory neuropathy. These are the investigation we ordered, and his fasting blood sugar was 154 milligram per deciliter. It was around above 150 during last three months also. His full blood count showed hemoglobin of 10.9 gram per deciliter, which is low, but MCV was normal, that is 85. His serum creatinine value was 1.89 millimole per liter with EGFR 37, which is CKD 3B category. Serum electrolyte, sodium 140, potassium 4.64, UFR albumin trace. But his urine albumin creatinine ratio was high, 584 milligram per gram. His liver function was normal, SGOT 18.2, SGPT 18.9. His serum total protein was normal, 73.7. Albumin also was normal, 43.3. ECG showed no LVH or any other abnormalities. We requested echo. It was 18 when I took this case. His ultrasound abdomen showed normal size kidneys with increased cortical echogenicity, suggestive of diabetic nephropathy. His calcium and phosphate level and lipid profile was elevated. So we made the diagnosis of CKD, which is probably due to diabetic nephropathy and uncontrolled hypertension. So he had a few problems we identified. First one is type 2 diabetes mellitus with poor glycemic control with 4 oral hypoglycemic drugs, and hypertension, which also was uncontrolled, dyslipidemia, and newly diagnosed CKD stage 3B, and he had a few economical problems due to inadequate income. So first of all, I counsel about his condition, and possible health issues can arise due to the diabetes, hypertension, and I explain how this condition affect his organ system, especially it had affect his kidney already, and possible cardiovascular outcome, and I explain about the prognosis of this disease and disease. Then I manage him with explain him about importance of insulin therapy to prevent further damage to the kidney and to achieve a proper glycemic control. But practical situation, he couldn't go for insulin therapy because he's a manioc vendor. He go for work early in the morning around 4 a.m. and he outside the home throughout the day, and he explained, according to his explanation, we also realized that he cannot go for insulin at the moment. So we decided to increase his oral hypoglycemic drugs further. We continue routine drugs, and we increase his glycoside dose from 80 milligram BD to 120 milligram BD. At the same time, we added calcium carbonate 500 milligram BD and 1-alpha cholecalciferol 0.25 microgram daily for renal protection, and we referred him to a medical nutrition therapy. So I advised him, I gave him health education on diet and exercise, and give dietary advice regarding to avoid green leaves and yellow vegetables, and protein restriction and adequate water intake, and the limit water about 1.5 liter per day. So this was my case. Actually, there are many patients like this coming from nearby hospital, at least one person per day, due to this renal involvement, due to most often due to diabetes as well as hypertension.
Before you start this, the guideline management, I would like to tell you the take-home message of this patient is, whenever such a patient comes with, the decreased liver, the renal function, so what our, the responsibility is, mainly we have to focus, not to, the progress that renal function furthermore, right? For that, you have to identify from the patient, from the perspective of patient, what are the problems, the created to exaggerate her kidney damage. Here, particularly for this patient, there are two prominent obvious factors we have identified. That is, one thing is uncontrolled blood sugar as well as uncontrolled hypertension. For this patient, it was around high blood pressure is around diastolic pressure around 95%, where we need to control it to the 130/80, like, because sometimes now new guideline says it should be below, it should be around 120/80, right? So because of that, it's very important for us to maintain the blood pressure so that the renal perfusion will happen properly. So, and the other thing is hyperglycemia is the one, reduce renal perfusion, so that the other glomerulus also, the rest of the glomerulus which are functioning also will go into the dysfunction. So that is the prime responsibility that family physician need to be think of, right? If the patient is particularly, some patients may be having, the chronic infections may be going on, like urinary tract infection unnoticed, particularly in diabetes. So because of that, before you confirm that, this is, the chronic renal disease, CKD. So you have to take QFR and exclude underlying possible, the acute cause for the patient, because it may be sometimes, even though they refer from there, they also missed it. So maybe the underlying urine infection has given him the acute renal shutdown. So it definitely you have to exclude, even though the history is suggestive of the chronic nature, like the long duration of diabetes and hypertension, but still you have to exclude the acute urine infection by doing urine full report, which we have done. That is normal. So we have confirmed now this is CKD and stage as well. But what you have to think about, so what are the things that here his pressure is high, so we have to optimize the management of, the blood pressure by giving him advices for this low salt diet, as well as, the adjusting hypertensive, antihypertensive treatment, optimizing the treatment, right? That is very, very important. And number two is the hyperglycemia. There is HbA1c is high, and because of that, we need to. So he is always scared about the insulin. He says that he can't. So in such a way, so we have to find out. Being EGFR is 37. So what are the other possible the things that according to this patient? Because otherwise, even though we say whatever, how much to go with insulin, if the patient doesn't like, then we have to think of other possible options like optimization of current, the oral hypoglycemic, which are safe in renal failure as well. So they are, because now it's 37, still we have the chance of, the giving him, optimizing the EMPA, if the patient is on EMPA to 10, if he was on, we can increase to 25. And even there is sitagliptin, very safe groups are available for the renal function, low renal function, like linagliptin. Like that, we have to discuss, right? Particularly in your exam, if you do this with your patients only, it can come to your knowledge at the exam. So because of that, so you have to be very much alert about the problems of the patient and identify that particular problem among this patient, and then try to correct it at the management to arrest. And the same time, you have to give the supportive treatment for the patient, like the reduction of total fluid volume and reduction of fruits, the serum potassium, and support of the calcium supplementation, like 1-alpha, right, and as well as calcium carbonate. Like that, you have to give a very good insight about the patient by doing a proper counseling for this particular patient to go ahead with the adjusting the pharmacological regime, and to improve the knowledge about how important these non-pharmacological methods in order to, and not only that, the follow-up. So follow-up of renal functions in 3 months, particularly for a male, you have to check, not only the KUB, but prostate as well by ultrasound scan as well. There may be some, some, the underlying causes that can, create for this type of renal damage. So because of that, you have to get that into mind to identify what are the issues among the patient, and then to arrest this progressive renal damage by, avoiding those factors and correct advices and the correct, the safe management plan. Okay, but because below in other countries, according to the guideline, 15 in-stage renal failure, and some, the issues only we have to refer. So other than that, we can manage the patients, right? So think about that, and don't think that even though if the VGFR is coming down by 10 or 20 less than normal, better not to send. So you have to identify correctly if you are competent about the patient management at primary care. That is our management. then necessary only we have to send them to the renal and get their opinion for the follow-up. Okay, so now Tharanga, you can start your guideline management discussion.
Okay, madam, thank you.
Okay.
This is about diabetic kidney disease management. So I first tell you the sources I went through the KDIGO guideline, that is Kidney Disease Improvement Global Outcome, which is the most commonly accepted guideline in the world, and our nephrologists also usually follow the KDIGO guideline. And I also get information from NICE guideline and UpToDate as well. So first of all, we start from the definition of the CKD. There are criteria to diagnose CKD, that is any structural or functional defect of the kidney which should last for more than 3 months. The functional abnormality may be albuminuria more than 30 milligram per gram, or urine sediment abnormalities like granular cast, RBC, persistent hematuria, or any electrolyte and other abnormalities due to tubular disorders, or abnormalities detected by renal histology, and structural abnormalities detected by imaging like polycystic kidney disease and portal echogenicity differences, and history of kidney transplantation. If these are present more than 3 months, it is chronic kidney disease. And functional criteria are GFR less than 6 milliliter per minute per 1.373 square meter for more than 3 months. Basically, CKD is any structural or functional abnormality of the kidney which is persisting for more than 3 months. So when patient come to us with high serum creatinine to confirm CKD, we should do serum creatinine after 3 months. If persistently high, then we diagnose CKD. So there are 6 grades of CKD. Normal GFR is more than 90. Then grade 1 chronic kidney disease is GFR more than 90, but there are some structure abnormality. Grade 2, GFR 90 to 60, and grade 3 divided into grade 3A and grade 3B. 3A means 59 to 45. 3B is 44 to 30. And stage 4 CKD is GFR 29 to 15. Grade 5 is end-stage renal failure, which is less than 15. So, to diagnosis of diabetic nephropathy, in type 1 diabetes, usually diabetic nephropathy occur after 15 to 25 years after the diagnosis. But in type 2 diabetes, it can be present at the diagnosis of diabetes. So when patient comes with type 2 diabetes, at the first visit, we have to check for diabetic nephropathy. Usually diabetic nephropathy patients are asymptomatic until the stage of 4 to 5. That means when GFR going below 30, patient going to get symptoms. Until that, usually no symptoms of CKD. So diagnosis is persistent albuminuria more than 30 microgram per milligram creatinine. Need 2 values 3 months apart. So, GFR less than 60 milliliter for 3 months or more. As diabetic nephropathy diagnosis is same as CKD diagnosis, the presence of diabetes. So the progression of albuminuria is initially it is microalbuminuria, which is between 30 to 300 microgram per milligram. Then it become intermittent proteinuria and persistent proteinuria. During these stages, serum creatinine level is normal. After that, the serum creatinine begin to rise. and 50% go to end-stage renal failure in 5 to 10 years, usually. In some cases, 10% of diabetic nephropathy patients don't have albuminuria at all. So, if when in the absence of albuminuria, we cannot exclude diabetic nephropathy. So, this is albuminuria categories. There are 3 categories: A1, A2, and A3. A1 is actually no albuminuria, that is less than 30. Less than 30 milligram per gram, and A2 is microalbuminuria, that is 30 to 300, and A3 is macroalbuminuria, that is more than 300 milligram per gram. So this is CKD risk map. When patient come to our clinic, we have to check the risk category of the patient. For that, we should have the microalbumin urine level and the serum creatinine. From the serum creatinine, we can calculate EGFR, and x-axis is EGFR. The category of the renal failure according to EGFR, and y-axis is category gradient of the albumin urea. A1 is normal to mildly increased albuminuria. A2 is moderately increased albuminuria, which is that is more than 300. So according to this graph says, green color squares are low risk, then we can monitor, and yellow color squares are moderate increased risk, and orange color areas are high risk. Red color area is very high risk, and dark red area is highest risk. And the we have to refer the patients in this red area and dark red area. It is all indicated in this graph. This graph is very important while we are managing the patient in the clinic. So this generally indicate more when there's a more proteinuria, and the higher the grade of the CKD, the risk is more. This is CKD risk map. So signs and symptoms of diabetic nephropathy. Diabetic nephropathy should be considered in patients who have diabetes mellitus and history of one or more of the following: passing of foamy urine, otherwise unexplained proteinuria, diabetic retinopathy, fatigue and foot edema secondary to hypoalbuminemia, because some diabetic patient has severe proteinuria, which can lead to nephrotic syndrome, even nephrotic syndrome. And other associated disorders such as peripheral vascular occlusive disease, hypertension, coronary artery disease. When these conditions are present, it is likely to have renal involvement as well. Another feature is hypertension. So management of CKD, we aims at the identify and treat the etiology. Like in this case, the etiology is diabetes and hypertension, and some cases obstructive uropathy. Likewise, we should identify the cause for the CKD and treat that. Sometimes that can be reversible, and slow down the decline in GFR, prevent the complication of CKD. The main thing that a primary care physician, as primary care physician, we should do the slowdown of the decline in GFR. So there are several measures to do that. I will discuss in future slides. And treat the symptoms of complication. Like some patient get itching due to uremia. So we have to symptomatically treat those patients and address the psychological aspect of the patient. Timely dialysis and planning KT. This is usually belong to secondary and tertiary care level, and palliative care that is done by us. So this is an important slide because these are the referral criteria to a nephrologist. When patient comes with high serum creatinine, we have a doubt whether to refer for a nephrologist or not. So it is not needed to refer all the patient to nephrologist, because to some stage we can, as primary care physician, we can manage a patient very well. And if these criteria are met, we have to refer for nephrologist for shared care. So there are 8 criteria which need to refer. First one is 5-year risk needing renal replacement therapy of greater than 5%. This is measured using a 4-variable kidney failure risk equation. This equation is available in the internet. We can just check in the clinic and we have to provide some information. Then we get the 5-year risk of needing renal replacement therapy for the patient. If it is more than 5%, we have to refer. Second one is urine albumin creatinine ratio more than 70 milligram per millimoles. That means 6 to 20 milligram per gram or more. If heavy protein urea, again we have to refer for the nephrologist unless known to be caused by diabetes and already appropriately treated. And third one is urine albumin creatinine ratio more than 300 together with hematuria. So both should be present, more than 300 plus hematuria. And fourth one is sustained decrease in EGFR of 25% or more. And change in EGFR category within a year. If within a year, if a patient in stage 3 go for stage 4, then we have to refer. A sustained decrease in EGFR of 15 milliliter or more per year. If patient GFR persists to decline by 15 milliliter per year, then again we have to refer that patient. Hypertension that remains poorly controlled despite the use of at least 4 antihypertensives, that is resistant hypertension, again we have to refer. Known or suspected rare or genetic causes of CKD. For example, adult onset polycystic kidney disease, then we have to refer. Suspected renal artery stenosis, then again we have to refer. Even with these referring criteria, adult with refer adult with CKD for specialist assessment, taking into account their wishes and comorbidities if they have any of the above. Even with this thing, we have to consider the patient wishes and comorbidities before referring. So this is the overall management of a CKD patient. All the patient need good blood pressure control, glycemic control, proper nutrition, exercises, and proper lipid management and smoking cessation. That is common for all patients. And most patients with CKD will get SGLT2 inhibitors and renin-angiotensin system inhibitors. These are the most important drugs we are using to prevent the progression of CKD. And some patients receive antiplatelet only for secondary prevention. If patients are having ischemic cardiovascular or cerebrovascular event, then we can offer antiplatelet drugs. Otherwise, that is not indicated in CKD. So these are the measures to for the prevention of progression of CKD. That is the most important part. As primary care physician, we have to do in our clinics. That is tight blood pressure control and maximum RAS blockage. RAS means renin, angiotensin, aldosterone system, and tight glycemic control, low salt intake, low protein intake, and avoid nephrotoxins. These all are to prevent the progression of the CKD. So the hypertension management guidelines, according to KDO guideline, the BP target is for all patients, it is less than 1. Systolic blood pressure less than 120. That is the KDO guideline. That has some difference between NICE guideline. According to NICE guideline, the BP target, if patient is having protein urea, that is urine albumin creatinine ratio than 30 milligram per millimoles, then the blood pressure target is 130 by 80. If no protein urea, the blood pressure target is as other patient with hypertension, it is 140 by 90. So even though KDIGO guideline says it is the target is less than 120, it also says consider less intensive BP lowering therapy in people with frailty, high risk of falls and fractures, very limited life expectancy, or symptomatic postural hypertension. In these patients, the 120 target we can change. It's okay if it go more, 130 or 140. So blood pressure control targets are like that. Then the first drug we are going to start, if there are no contraindication, it is ACE inhibitor, angiotensin 2 receptor blockers. So we are going to start slow, and we titrate up to maximum tolerated dose. As example, we are going to start losartan, the maximum tolerated dose is 50 BD. We should go up to that to control blood pressure as well as reduce proteinuria. And second, calcium channel blocker. As some research proven, diltiazem is preferred drug because it can reduce the proteinuria as well. And third line, thiazide diuretic or thiazide-like diuretic, and thiazide-like diuretic are preferred. Indapamide is quite commonly used drug in Sri Lanka for this purpose. After this three drug combination, going up to maximum doses, if BP blood pressure is still not under control, then we go for step 4 management. For this step, we have to check the serum potassium level first. If the serum potassium level less than 4.5 millimoles, we can add spironolactone. We can add initially 25 milligram, and we can go up to 100. That is maximum dose for hypertension. Then at the step 4, if the serum potassium level more than 4.5, there are two options. We have two options. First one is a long-acting alpha blocker, which is prazosin, the drug we have, or a beta blocker. According to guideline, it is long-acting alpha blocker, which is not available in government sector. It is only available in private sector. There are some brand names with 2.5 and 5 milligram, but in our setup, in our clinic, we are not going to start. We are starting prazosin 3 times daily doses. That is not long acting. We are starting from 0.5, and we can go up to actually it is maximum dose is 40 milligram, but it is not tolerated by patient. As I have seen, it is going up to about 3 milligram TDS. That is 9 milligram per day daily doses. Like we can titrate up according to blood pressure and patient tolerance. So after this treatment, if blood pressure is still not controlled, then it is resistant hypertension. We have to refer for secondary or tertiary care. In the management of blood pressure in CKD, loop diuretics, that is furosemide, has significant role because it can act in low GFR, even less than 30 GFR 30. It can use especially if fluid load, especially if there is fluid overload. And in CKD, we can combine thiazide and loop diuretic at the same time. So this is maximum. We have to go for maximum renin-angiotensin-aldosterone blockage because to prevent the progression of the kidney disease. These drugs reduce the intraglomerular pressure and prevent further damage to the kidney. And this is the system. And initially the angiotensinogen, it converted into angiotensin 1 by renin, and angiotensin 2 by angiotensin converting enzyme from the lung. And angiotensin 2 is the drug which has many action on kidney, and it increase the aldosterone fixation. So we can block this system at several levels. First, then we can use renin inhibitors. that is actually not available in Sri Lanka. We have angiotensin ACE inhibitors or angiotensin receptor blockers, which block the angiotensin 1 convert into angiotensin 2, and we can also use aldosterone receptor blockers, that is spironolactone or phenylalanine. That's also a RAS inhibitors. So a little bit about this ACE inhibitors and ARB. Indications are if there's a proteinuria, that is urine albumin creatinine ratio more than 30 milligram per millimoles without hypertension, we can start ACE inhibitor or ARB. If blood pressure is high without proteinuria, again blood pressure is more than 140/90 without proteinuria, again we can start ACE inhibitor or ARB. So we have to titrate up according to the UACR, not according to the BPR, because our main aim to reduce the proteinuria. So if tolerable, the BP is not going down much more, then we can go for maximum doses to reduce the urine albumin creatinine ratio. And there are some precautions we have to take while giving ACE inhibitor and or ARB. First one is hyperkalemia. If serum potassium level more than 6, then we have to directly stop the drug. And if serum potassium level between 5.5 to 6, we can continue RAS blockage at a reduced dose. We have to half the dose when the patient was on. And we have to at that
Tharanga, I can't hear you. No. Tharanga?
can you hear me now?
Yeah, can.
Okay, other questions are
So current slides are not up. All right, okay.
okay. Other questions for ACE inhibitor and ARB are angioedema and flash pulmonary edema, which is a quite serious condition, need immediate admission. This is regarding a guideline about renin angio, this ACE inhibitor and ARB, which I discussed already. So other thing, RAS inhibitors are spironolactone and phenylalanine. Spironolactone is a steroidal mineralocorticoid receptor antagonist, and phenylalanine is non-steroidal. And in CKD, we can use only phenylalanine. Spironolactone cannot be used to use as a RAS inhibitor, but phenylalanine is not available in Sri Lanka. So mineralocorticoid receptor antagonists we don't have to have for this purpose. This is about this phenylalanine. So other drug is again renin. The RAS inhibitor is the renin inhibitor, that is aliskiren. Again, that also not available in Sri Lanka. So to reduce proteinuria, we have ACE inhibitors and SGLT2 inhibitors in Sri Lanka. In diltiazem and clonidipine are also used as anti-proteinuria drugs, but not incorporated into European or UK guidelines, as the trials were done in Japan and India. So when we are going to add a calcium channel blocker in CKD patient to treat hypertension, if patient is having proteinuria, it is better to add diltiazem instead of amlodipine. So this is about SGLT2 inhibitors. SGLT2 inhibitors are the emerging group of drugs which has a lot of cardiovascular and renal benefit. In CKD, it has few indications. First one is if patient is having diabetes, yes, SGLT2 is a first line drug. If patient has no diabetes, but if patient is having proteinuria that is more than 200 milligram per gram, then we can start SGLT2 inhibitors. But we have to stop it when the GFR goes below more than 20. So these are the KDIGO guideline about glucose SGLT2 inhibitors. So this is blood sugar management. That's all for blood pressure management. This is blood sugar management. So our HbA1c target is there's a range. It is range from 6.5 to 8. Usual target is in young patient, it is 7%. But in CKD, there's a range according to the patient characteristic, it differs. So it depends on this chart show the target depends on the severity of CKD. That if in early grade, grade 1, 2, we should have tight glycemic control. So our target's close to 6.5. In end-stage renal disease, our target is not that tight. It is close to 8 or 7. Likewise, that depend on the severity of CKD, microvascular complication, and comorbidities, life expectancy of the patient, hypoglycemic awareness, resources for hypoglycemic management, and propensity of treatment to cause hypoglycemia. All these factors, the target depends on all these factors. So HbA1c may be inaccurate in advanced CKD. So in stages 4, 5, the HbA1c level may not be accurate. So in that case, we have to go by fasting blood sugar values and postprandial blood sugar values. So we need multiple values about three times per week. So from this slide, it's HbA1c target range from 6.5 to 8. So management, lifestyle therapy, first line therapy, we can categorize as lifestyle therapy, first line therapy, and additional therapies as needed for glycemic control. Lifestyle therapy include physical activity, nutrition, and weight loss. And first line therapy include metformin and SGLT2 inhibitors. And additional therapy include other oral hypoglycemic drugs and the insulin. So this is the lifestyle therapy. As in other diabetic patient, we are giving advices to stop tobacco and quit smoking. And we talk about the protein intake and sodium intake with this patient. In CKD patient, the recommended protein intake is 0.8 gram per kg per day. That is one small piece of fish or meat. So we have to restrict protein in CKD patient, especially animal protein, hazardous for the kidney. And the other thing is sodium intake. The recommended sodium intake is less than 5 gram per day. That is a small teaspoon, less than teaspoon. So the physical activity recommended is moderate intensity physical activities are recommended. That is about exercise for 150 minutes per week. These are the lifestyle therapy. And this is about protein intake that I told just now. And drug treatment, the first line drugs are, there are two first line drugs, metformin and the SGLT2 inhibitors. So metformin, we can start metformin until if GFR more than 45, we have to stop at the GFR 30. So we are not initiating when GFR less than 45. So in between GFR 45 and 30, the maximum dose is 500 milligram BD. We can't go for 1 gram BD, which is the normal dose in other normal people. The main thing is we have to stop metformin at the GFR of 30 to the risk is not the renal damage, but the lactic acidosis. So the SGLT2 inhibitors, that is empagliflozin, dapagliflozin, those also are first line therapy. But their glycemic control is mild to moderate, not as much as metformin or sulfonylurea, but it has improved cardiovascular outcome and reduce CKD progression and reduce proteinuria. So the recommended dose for the empagliflozin, which is most commonly used drug in Sri Lanka from SGLT2 inhibitors, that is 10 milligram to 25 milligram. For these purposes, 10 milligram dose is adequate. That provide maximum cardiovascular and renal benefit. If for the blood sugar control, we can go up to 25 milligram per daily. It can cause reversible decline in eGFR initially, which does not necessitate dose reduction. If GFR is reduced more than 30, there's a risk of blood pressure reduction. In that case, we have to reduce the dose of diuretics, not the SGLT2 inhibitor. In critical illness, we might need to stop SGLT2 inhibitor and start insulin. The second line drug is GLP-1 receptor agonist. This drug also has cardiovascular benefit and renal vascular benefit and reduce proteinuria. The problem is GLP-1 receptor agonists most are injectables and high cost and not available in government sector. But these are very good drugs because they have cardiovascular and renovascular good outcome. And it can be used even at the stage 4. When eGFR, we have to stop them when GFR falls below 15. It is not recommended to combine DP4 inhibitors with GLP-1 receptor agonist. These are some details about GLP-1 receptor agonists. These are the drugs: deglutamide, dexenatide, liraglutide, semaglutide. These most are injectable, and semaglutide has oral forms, but these are not freely available in Sri Lanka. These are the special consideration. Madam?
Yes.
Madam, you told that you want to tell something about this.
No, the thing is, the special consideration in the sense, when you are going to select, the tailor-made treatment for particular patients, who you have to consider, the other comorbidities, and as well as, the patients, in the patient's perspective, whether the patient is obese patient, or whether the patient is young patient, or the patient is, elderly one. Because thinking about that, you have to, select the pharmacotherapy in different occasions, not because we can't uniquely, give the same way the treatment for each patient. So that is a very important thing. So in case of, because eGFR is 30, 7 now, it's imminent to go for the 30 and then the declining. So you have to think about control of other comorbidities as well. And other important thing is selection, because insulin is the best at this stage, but below 30, it's no matter what it is, you have to go for the insulin, right? That is the treatment of choice according to the guideline management. But our country, the problem is patients are more reluctant to insulin. But in such a case, you should not, you have to anyhow put your maximum effort to encourage them for insulin by telling the positive effect of it and the very much, the painless injections compared to the other injections going for intramuscular, and as well as train the patient for the dose at the trainer or with you. Then patient may be compliant enough. Other than that, if you just, give them insulin and just forget about the patient will not take it. So the rapid, the decline of kidney deterioration will occur. So we are going to lose the patient. And the other thing is, when you are selecting, GM, particularly this one, minimum doses are the good in this EGFR low patients, because the drugs, majority of the drugs are being secreted from the kidney. So in case of the renal function is less, in the sense it's not, the excreted. So there may be side effects. So that's why we have to be very much careful about the drug selection. So whenever the young patient, elderly patient, even though the potency wise, weight, sorry, it disturbed due to call. So, and the other thing is, when you are going to select the categories, also same, right? Because now these SGLT2 inhibitors are being used for without having diabetes for, the cardiovascular safety as well, because remodeling would be the best with that drug. So if the patient is having cardiovascular comorbidities and the renal insufficiency, then it's very good drug to, the use, right? So because of that, in that way, you have to, go ahead, that there are some, the tailor-made, the group of drugs among these SGLT, any drug. So any drug groups, here the linagliptin would be the best for the reduced EGFR. So but patient can't afford. So in such a case, we have to go for the available drug. But if patient can afford, and telling about the disease and the severity of, the worst ends like the renal dialysis, and as well as renal another transplant. And once you mention about those things, patient will be motivated to find out, the money to buy these drugs. So carefully, so you have to select who the patient is with the capability of, the financial status, as well as the understanding of the disease process when you are going to the prescribed medicine. Otherwise, in primary care, if we are going to take the responsibility of the patient, right, to manage this. But if you are not, the carefully handle the patient will be ended up with, the end organ failure, the end stage renal failure. So that much of irresponsibility you can't. So that's why selection of patient particularly, right, considering his other comorbidities and understanding the level of education, it's very important. You have a huge role to do with your trained team of the nurses for insulin, injection and detection of, the progression detection in 3 months interval by again checking the patient's serum creatinine levels and other this thing. And as well as, that there are some other issues as well. You have to frequently check for serum electrolytes, and as well as, you have to check for the HbA. Here our patient is hemoglobin is low, right? In such a case, once the blood picture comes and the patient is pale and with symptoms of, the anemia, we have to think about giving erythropoietin as well, which we can give, right? We are giving. In our clinics, we are giving. We are arranging and giving. So that is not a renal, the specialist problem always. So because of that, we have to have the competency. But we have to be responsible primary care physician in order to manage such patients. So we can do. So that is why you need this evidence-based knowledge. And the drugs, the other thing is, commonly when you are selecting drugs, for obese patient, metformin is all right, provided that eGFR is reasonably high. And the other thing is, but anyway, for the elderly people who are having no insulin, the no Langerhans reserves to, the produce insulin, no point of overloading the patient with, this one, sulfonylureas. Then patient will be ended up with, the hypoglycemias and all. So like that, you have to think rationally and, the prescribe the medication. That now you can start, Tharanga. I just want to brief the outline of it.
Okay, madam. So after main drugs, that is metformin, SGLT2 inhibitors, and GLP-1 receptor agonist, we have other drugs for add-on therapy when still if the blood sugar control is not optimal. This is DPPO inhibitors. Even though the HbA1c reduction is not much, just below 1, it is safe drug to start in CKD. For example, sitagliptin, linagliptin, and saxagliptin. Linagliptin is renal friendly than other drugs. There's no necessity to dose reduction in renal disease. We can give normal doses in renal disease, the linagliptin. But sitagliptin, which is a drug we are using commonly in private sector, in government sector, there should be dose reduction when GFR goes down. GFR between 50 to 30, the maximum dose is 50. If GFR more than 50, we can go up to 100. If it is 50 to 30, the maximum dose is 50. When GFR go below 30, the maximum dose is 25. The advantage of DPPO inhibitors is hypoglycemia risk is less. And sulfonylureas are third-line drugs after metformin, SGLT2 receptor agonist, and GLP-1 receptor agonist. Then sulfonylurea, we can add sulfonylurea, but the problem with these drugs are mainly the hypoglycemia. And this drug doesn't have cardiovascular morbidity benefit, but their HbA1 reduction is greater. Just close to metformin, it is around 1.5. These drugs primarily metabolized by the liver, and glipizide and glycoside we can use. Glipizide is the shortest acting. No dose adjustment is needed in CKD. Glycoside is the widely used drug in government and private sector. If GFR is more than 60, no dose adjustment is needed. If GFR between 16 and 15, we can use glycoside, but with caution because it can cause hypoglycemia. So we have to start them at a low dose, like 40 milligram daily, and we can gradually increase the dose 40 BD and up to 160 BD. The maximum dose is 320 per day. And we have to stop glycoside when GFR falls below 50. So glibenclamide is best avoided in renal disease because it causes profound hypoglycemia and increase the mortality of patients. And the well-known side effect of this sulfonylurea is weight gain. But in recent studies, it shows that glycoside, that the drug we are commonly use, does not cause weight gain like we earlier thought. The last drug group is alpha glucosidase inhibitor, that is acarbose, which is not a preferred drug in CKD. And it has to be avoided when the GFR goes beyond less than 25. So after all, when there's a oral hypoglycemic drug failure, the insulin therapy is the best to start. It has these indications are similar to other DM patient when oral hypoglycemic drugs fail to control the blood sugar. No dose adjustment is required if the GFR is more than 50. The insulin dose should be reduced approximately 75% of the baseline when the eGFR less than 50 up to 10. Because the insulin is excreted from the kidney when there's renal failure, no excretion, though insulin level goes up in the blood, so which cause hypoglycemia. To avoid that, when GFR goes down, we have to reduce the insulin dose as well, with careful monitoring of the plasma fasting blood glucose. And the dose should be reduced by as much as 50% when the GFR falls below less than 10. When end-stage renal disease, we may have to half the dose, half the insulin dose, which is patient was earlier. The other most important thing is lipid management in CKD, because chronic kidney disease patients, the mortality is not mainly due to renal failure, but from the cardiovascular events, either ischemic heart disease or cerebrovascular disease. So we, at the same time, we are managing the renal disease, we have to focus on cardiovascular and cerebrovascular mortality. So lipid management is very important in that case. In renal failure patient, they have increased incidence of cardiovascular events. So we should go by individual lipids target according to the CVD risk. Apart from that, when renal failure patient, if patient is more than 50 years and GFR less than 60, even without other risk factors, we have to start statins or statin with ezetimibe. I will tell it again. When there's a CKD and eGFR less than 60 and patient age is more than 50, without considering other risk factors, we have to start lipid lowering therapy, either with statin or statin with ezetimibe. If patient is more than 50 and GFR more than 60, then again we have to start statin. Patient age between 18 to 49 with CKD, then we have to go by individual risk target. Yes. Okay, then after hypertension, diabetes, then the other important thing we have to manage in CKD patients is mineral-borne disease. So disease systemic representation of the vitamin D metabolism. I will go through this quickly. 7-dihydrocholesterol with the help of sunlight converted into cholecalciferol, that is vitamin D3, which is go to liver and converted to 25-hydroxy D3. And at the kidney, by 1-alpha hydroxylation, it become 1-alpha dihydroxy vitamin D, which is the active form, which is also called calcitriol, which acts on target tissue, intestine, kidney, and bone. In CKD, this last step is impaired. That is 1-alpha hydroxylation is impaired. That lead to vitamin D deficiency, and then hypocalcemia and hyperphosphatemia, which hyperparathyroidism. That is the basic of mineral-borne disease. So the effect of CKD on vitamin D and calcium metabolism, as I told in previous slide, there's a 125-dihydroxy cholecalciferol deficiency. So, circulating calcitriol, calcitriol means 125 dihydrocholecalciferol level begins to fall when the GFR falls below 40. This renal, the 1-alpha hydroxylation become impaired when the GFR goes below 40 usually, and it is markedly reduced in end-stage kidney disease. This lead to reduced calcium absorption from the gut, which lead to hypocalcemia initially, and increased parathyroid hormone secretion due to a negative absence of feedback effect from the calcium. Both hypocalcemia and hypophosphatemia lead to hyperparathyroidism. This increased PTH level in turn cause bone reception and problems in the skeletal system of the body. And renal failure itself lead to phosphate retention from the kidney, which lead to hypophosphatemia. All these changes ultimately lead to hyperparathyroidism, osteomalacia, osteoporosis, osteosclerosis, and adenine bone disease, which impose on great risk of fractures, bone pain, and other symptoms. So this illustrates the frequency we should monitor the serum calcium, phosphate, and PTH level. So we have to go to therapies according to the serum calcium, phosphate, and PTH level. We don't have PTH measurement freely in our hospital, but we can measure calcium and phosphate level and do our management in our hospital. In stage 3A and 3B, we have to check serum calcium and phosphate every 6 to 12 months. In stage 4, we have to check calcium and phosphate every 3 to 6 months. In stage 5, we have to check calcium and phosphate every 1 to 3 months. And according to this level, we have to continue our treatment. So treatment target in mineral bone disease is a normalization of the serum calcium and phosphate and avoid hypercalcemia. We have to avoid the hypercalcemia also, because when we see CKD patient, we are going to add calcium carbonate and 1-alpha. If we are going to high doses without monitoring the serum calcium, it can cause hypercalcemia. So hypercalcemia in turn cause vascular calcification and vascular event. So it is important to prevent both hypocalcemia as well as hypercalcemia, and lowering serum phosphate toward the normal range. These are our treatment target: avoid hypercalcemia, lowering serum phosphate towards the normal range, and lower the parathyroid hormone level to 9 times the upper limit of the normal. Usually, we don't have the facilities to check parathyroid hormone level in our clinics. So treatment should start according to the serum calcium, phosphate, and PTH level. Initially, dietary modification when the serum phosphorus level is above normal. That is more than, if phosphate level is more than 4.5, we are starting a dietary modification. Only start phosphate binders when the serum phosphate level is persistently elevated more than 5.5. Even with dietary restriction, if the phosphate level is still high, we go for phosphate binders. So these are the drugs we use for hypophosphatemia. There are 2 types of phosphate binders: calcium containing phosphate binders and non-calcium containing phosphate binders. These non-calcium containing phosphate binders are the preferable because they won't cause hypercalcemia. These are 2 drugs: sevelamer hydrochloride and lanthanum. Sorry for the slides. Excuse me. Sorry for the disturbance. So calcium containing phosphate binders are calcium carbonate and calcium acetate. It is calcium carbonate is the drug we most commonly use in our clinic. That's main purpose is to reduce the phosphate level and not the calcium supplementation. So the usual doses are calcium carbonate 1250 milligram 3 times daily with meals. When it's given with meal, they prevent the phosphate absorption. So for hypocalcemia, the calcium containing phosphate binders had other benefits. They provide some calcium. Apart from that, we can use vitamin D preparation. There are 4 types of vitamin D preparation. That is cholecalciferol, that is vitamin D3, and ergocalciferol, that is vitamin D2, also called calciferol. And other thing is alpha calcidol, that is 1-alpha, that is a drug we are using in our clinics. Alpha calcidol, that is come as 1-alpha CCF. The usual doses are 0.25 to 1 microgram per day. And calcitriol is also potent vitamin D analog, that is 125 dihydroxycholecalciferol, that also used as 0.25 to 1 microgram per day. In patient with CKD stage 5 requiring parathyroid hormone lowering therapy, the SCADIGO has suggested calcium mimetic, calcitriol, and vitamin D analogs, or a combination of calcium mimetic with calcitriol or vitamin D analog. When hyperparathyroidism, this combination has been suggested by KDIGO, that is calcium mimetic. Calcium mimetics are new drugs that reduce the PTS secretion. And calcitriol is a vitamin D analog, and yes, these drugs can be used to lower the PTH. The other complication of chronic kidney disease is hyperuricemia, because kidney cannot excrete uric acid. Then there's a uricemia, hyperuricemia, which can cause gout, uric acid stones, and uric acid nephropathy. To prevent those complications, when patient is having symptomatic hyperuricemia, that is gout, joint pain with hyperuricemia, then we have to give treatment. That is xanthine oxidase inhibitor, allopurinol, which is the frequently used drug for this purpose, and there's other drug called febuxostat, that is less not commonly used in Sri Lanka for this purpose. So for hyperuricemia guideline is when there's a symptomatic hyperuricemia, we have to treat with allopurinol. Usual dose is 100 to 600 milligram per day. The other complication of chronic kidney disease is acidosis. That is that is a metabolic acidosis. In people with CKD, consider use of pharmacological treatment with or without dietary intervention to prevent development of acidosis. So in acidosis, we have to check serum bicarbonate level. Usually that is done in inward patients. If serum bicarbonate level less than 18, we have to go for bicarbonate therapy. That is sodium bicarbonate 600 to 1200 milligram per day. Other complication of chronic renal failure is hyperkalemia. The normal range of potassium is range from 3.5 to 5. The causes for hyperkalemia in CKD is multiple. The main one is impaired renal excretion due to renal failure itself. And some the drugs we are using in the CKD also causes hyperkalemia. The drugs are ACE inhibitor, ARB, spironolactone, and NSAIDs. These drugs, apart from NSAID, other 3 drugs are commonly used in CKD. So we have to use them with caution. And uncontrolled hyperglycemia and insulin deficiency also cause hyperkalemia, because when insulin is deficient, cells cannot intake potassium into their cells. So there's a relative hyperkalemia. And hypovolemia also lead to hyperkalemia. So this is the management of hyperkalemia. If patient come with high potassium level with symptoms like muscle weakness and paralysis, we have to admit this patient. And if patient is having cardiac ECG rhythm abnormalities like tall tented T waves in ventricular arrhythmias, then again we have to admit this patient. Apart from that, if serum potassium level is more than 6.5, without clinical muscle weakness or paralysis, again we have to admit. That is the cutoff point more than 6.5. If between 6.5 and 5.5, again patient is having significant renal impairment or ongoing tissue breakdown, which indicate it's a possibility of further rise in potassium, then we have to admit this patient. When patient has less than 5.5 and no severe renal failure, we can go for general measures to reduce hyperkalemia when the serum potassium level less than 5.5. So the measures include reduce the dose of ACE inhibitor or spironolactone, reduce the dose of or stop. And we can start diuretic therapy, furosemide or thiazide. Furosemide has great effect on hyperkalemia. If there's acidosis, bicarbonate therapy also lead to potassium reduction from the blood. And other thing we can use is gastrointestinal cation exchange resins. These are sodium polystyrene sulfonate. It binds potassium and remove from the gut. And at the same time, we have to advise to reduce certain foods. This is a list of foods. Generally, we ask to avoid yellow color fruits like banana, mango, and also coconut melons and green leaf vegetables. This long list you can read. So that is the hyperkalemia management. Then the anemia. Anemia is a very common complication in CKD. So anemia is defined as HB less than 13 gram per deciliter in men and less than 12 gram per deciliter in women. So when we suspect anemia in CKD patient, like patient is having fallow, then we have to do investigation, full blood count, retic count, serum ferritin and transferrin saturation. In our setup, we usually do full blood count and blood picture. In some selected patient, we do serum ferritin also. And we have to monitor the patient. Something happened. We have to monitor the patient in stage 3 annually, stage 4 twice a year, and stage 5 every 3 months. According to this we have to monitor the HB. And causes for anemia and CKD. There are multiple causes for anemia and CKD. The main thing is erythropoietin deficiency, because erythropoietin is mainly inside from the kidney. So in renal failure, there's a erythropoietin deficiency, which lead to normochromic nomocytic anemia. And increased blood loss, there may be occult GI bleeding, repeated blood sampling, and blood loss during hemodialysis. This can cause iron deficiency anemia. And bone marrow toxin, which is accumulated due to renal failure, also cause bone marrow suppression. And hematinic deficiency can be coexist in CKD, like B12 and folate. And increased red cell destruction. Red cell have a shortened lifespan in uremia. And ACE inhibitor itself can cause anemia in CKD. Mainly iron deficiency and erythropoietin deficiency we are going to treat in CKD patients. Anemia due to iron deficiency when the patient serum ferritin level less than 45 to 100 or MCV less than 80 femtoliter. And we should exclude other hemoglobinopathies like beta thalassemia trait. In this case, we diagnose iron deficiency and look for other causes for iron deficiency like PRBD, menorrhagia, and start iron therapy. So HB target in CKD is 9 to 10 gram per deciliter. That is very important when we are managing in the clinics. We should not target high HB values like 12 or 13. It is the targets given in the guideline is 9 to 10. That is a target. The other thing is IV iron is better than oral iron, but in our setup, we are giving oral iron, usually ferrous sulfate. Monitor HB and ferritin level every 3 months. So, anemia due to renal erythropoietin deficiency, this is also common in CKD. That is when HB is low, but MCV is within normal range. That is normochromic normocytic anemia, anemia chronic disease. So, we start a subcutaneous erythropoietin injection in this patient. The dose of erythropoietin depend on hemoglobin level and the body weight. Usual erythropoietin dose is 50 to 100 units per kg per week. And the problem with this erythropoietin therapy is it can cause hypertension in 30 to 30% of patients, but it is not a contraindication. We can control the blood pressure with antihypertensives and continue erythropoietin. Again, the HB target is 9 to 10 gram per deciliter, and we have to keep the HB below less than 11.5 gram per deciliter during erythropoietin therapy, because going beyond that, there's a risk of thrombosis, vascular access, MI, or cerebrovascular thrombosis. There's a risk. So we should keep less than 11.5. Monitor HB monthly initially and then 3 monthly. Stop if stroke or any other thrombotic event. If no response within 3 to 4 months, discontinue the treatment. If when we are giving erythropoietin but no hemoglobin rise during 3 to 4 months, then we have to stop the drugs. Usual regimen is 4,000 to 8,000 international unit per week. So this is about erythropoietin. So that is, I came to the end of the presentation. Do you have any question regarding this guideline? It is, I understand, little difficult to memorize at once. You have to go through these slides several times to keep this in memory. So do you have any questions? If no question, thank you.
Thank you, Dr. Tharanga.
Thank you.
B